Aloha, everyone. I want to welcome you to Queen's free Speaking of Health lecture. This is our monthly lecture that we have every month here at our Principal campus. Tonight's lecture is titled Advances in Hip and Knee Replacement Surgery. My name is Sean Ibarra from the Corporate Communications Department at the Queen's Health Systems, and again, we want to welcome you to this month's event. So our presenter this evening is Dr. Thomas Kane. Dr. Kane graduated from medical school at UC Davis and did his fellowship at USC's Adult Joint Reconstruction. He has been an assistant clinical professor of orthopedic surgery since 1992 and is board certified from the American Board of Orthopedic Surgery. Dr. Kane is currently medical director at the Queen's Joint Center and founder of Kane Orthopedic Institute. He has also been named as one of the best doctors in Hawaii by Honolulu Magazine since 1996. So please give a warm welcome to Dr. Thomas Kane.
Good evening, everybody. Thank you for coming out to the presentation tonight. As Sean said, I'm very grateful that they asked me to share with you tonight. I am Thomas Kane. My area of expertise is hip and knee reconstructive surgery. I'm an orthopedic surgeon. I was trained here in my residency at the University of Hawaii orthopedic program, and I did a special year of fellowship at USC doing exclusively hip and knee reconstruction. In 1992, when I started practice, I was the very first fellowship trained orthopedic surgeon in hip and knee adult reconstructive surgery. So I do my work at Queen's. I trained here. I'm loyal to Queen's, and since 2008, I've been the medical director of the Queen's Joint Center here. So it gives me a chance to keep my finger on the pulse of the entire medical center. From that perspective, I feel very privileged to have that. And I feel very privileged also to have you guys come out here tonight. If you think of questions, if you really want to have a burning desire, just raise your hand and we'll come up to you during the talk too. Or you can wait till the end. I'm very lucky to have with me tonight, besides members of my Joint Center team here, I have a very special guest, one of my very dearest patients, and he is quite an entertaining man, to say the least. And he'll get up and share his experiences with you. He had, I did his hip replacement 12 years ago, his knee replacement 13 years ago, and he'll kind of fill you in about that and also tell you his experience both before, during, and after. And feel free to ask him questions. He's one of the nicest human beings I've had the privilege of getting to know, and I really appreciate him coming out here tonight. So what we're going to talk about here, the topic is going to be advances in hip and knee replacement surgery. I assume because you're here, you want to know about this kind of stuff, and if you live long enough, your joints are going to eventually wear out more likely than not. Arthritis in general is basically a very prevalent disease. In a country of 300 million people, it affects at least 50 million people in the adult population. Hands, hips, knees are the most commonly affected joints. Other joints can be affected as well, but these are the big three. It usually begins as an aching or a swelling or a stiffness in the affected joint. Typically, you'll get out of bed in the morning, a patient that has arthritis, and they'll feel stiff. They'll have what we call a startup pain. The first couple steps is hard. The cartilage in your joint that you're born with is the cartilage you have to keep your entire life. It does not regenerate itself. No one has genetically unlocked the secret of regenerating cartilage. And so that's a problem that is being worked on feverishly. Until that point does occur, we have a lot of modalities that can help alleviate arthritis symptoms, and then we have ultimately a joint replacement that can basically fix the problem. The startup pain happens because the cartilage wears so thin, the joint can no longer be lubricated or glide on its cartilage. And so it's reliant on the synovial fluid in the joint, which is kind of like motor oil in your engine. So when you're sleeping at night, a lot of the patients will say, when I turn over at night or I get this aching pain at night, that's because the ends of the bone are touching the end of the bone. And when they get up, you've been sitting for 2 hours in a movie or in a restaurant, and then you get up to walk, the first couple of steps are kind of dicey until that joint fluid can lubricate it again. Hip and knee arthritis will affect 50% of people over the age of 55. Women are slightly more susceptible than men. It is the most common form of arthritis. You hear about rheumatoid arthritis. That's a special kind of problem. It's an autoimmune disease. It's way more rare. Osteoarthritis, the wear and tear type of arthritis, is the most common. Like I said, the cushioning and gliding cartilage gradually wears out, and then the joint becomes stiff, painful, and starts to cause pain and limitation of quality of life. The knees are more commonly affected than the hips, interestingly enough. It's about a 60-40 ratio, and the area of wear can be localized in the knee, just one spot in the knee, or it can be the whole knee joint in general. The symptoms, as I alluded to a few minutes ago, dull aching pain, some stiffness. It can come and go. You can have good days where you don't have any symptoms, other days where you do. It's often intermittent. You have the startup pain that I talked about after you've been at rest, and you go to take the first couple of steps. You could have difficulty ascending, descending stairs. Interestingly enough, going downstairs tends to be harder than going upstairs. And you can't walk as far as you want. You find excuses for not going to the mall and with your family, or if I'll sit in the car, why don't you guys go inside? You know, and so it's one of those things where it can be very subtle and insidious as it starts to have its onset. In the hip, the pain is felt in the groin. People you say, point to your hip, and they'll point right here to the side. And that's called the trochanteric bursa, the parts you can feel, that's the greater trochanter. And so the hip joint is actually right in your groin, and most patients think they pull the groin muscle on a chronic basis. It can radiate to your buttocks. It can also radiate down to your knee. Probably 10% of the patients that come in to see me talk about their pain in their knee, and they have minimal to no hip pain. That's because the same nerve that innervates the hip joint also innervates the knee joint. So as a hip and knee surgeon, the important thing for me is everybody comes in complaining of knee pain, I also have to examine their hip to make sure that that's not the problem. You'll notice the last thing you lose in hip arthritis is the ability to flex your hip. The first thing you lose is the ability to rotate your hip. You can't externally or internally rotate it, and you can't bring it out as far as you used to do from the other side. Patients will often report difficulty in putting on their shoes or socks. Here in Hawaii, we're blessed. We get to wear slippers most of the time, so that usually isn't an issue. On the mainland, it's a little different story. Ask that question there, and it's kind of like bunions. They're very rare in Hawaii because people don't wear shoes to squeeze their feet together. Hip arthritis is a thing called a differential diagnosis. As a hip surgeon, people come in, they got pain that like I was just describing to you. It's not always the hip causing the problem. It can be a lumbar disc, a herniated disc, a nerve root being pressed on that mimics the hip pain. It can be pain on the side of their hip. If they point right here, I'm looking at trochanteric bursitis or tendonitis. That's usually curable with an injection of cortisone. It can be sciatica. The sciatic nerve is in the posterior aspect of the hip. It's in the buttock, but also has its own typical manifestations and characteristics on physical examination. So it's important when a patient comes in, extremely valid. The young surgeons that I train here at Queens in our orthopedic residency program, I tell them, they've done national studies on doctors, and the average doctor, when you come in for your initial visit to the doctor's office, will interrupt the patient within 17 seconds of that patient starting to talk. And it's just because it's human nature. You know, you want to dig into this thing. And what I teach them is to do is ask an open-ended question, sit down at an eye level with the patient, and shut up. You know, and just listen to the patient. 75% of the time, the patient, if you allow them to talk, will never talk more than about 2 or 3 minutes. And during that 2 or 3 minutes, they'll give you their own diagnosis if you just listen to them. They'll tell you what happened, how long it's been there, what hurts, what doesn't, all those kind of things. And so let the patient tell you their story. A typical question would be, what brings you in today? And just let them talk. Bite your tongue, sit on your hands, don't get up, and sit there and pay attention to what they're saying because they're telling you what they've got. The physical examination is key. It's super important. After you've taken a thorough history, you want to get up and watch the patient. How they get out of a chair is important. You can see something right away, how they're sitting in the chair, even the position they have. If they have a hip or knee problem, they'll be accommodating a certain position for that joint. How they walk, watch them walk. Watch them walk down the hall, watch them walk back. Pay attention. Get them in, have them get up on the exam table. The little step stool that we use, it's important to watch how they use that. They'll take their good side and step up with the good side. When they come down, they'll either come down backwards or they'll come down with the bad side leading. Physical examination, extremely critical. I tell the residents, they'll check range of motion in a hip, and they'll move the hip back and forth like this. And I say, look, you're not exercising the patient. What you're doing is checking what the range of motion is, the absolute range of motion. And they'll get up and the patient will go, ow, and they go, really? Oh, and they would do it again. I said, don't repeat the ow. It's once is enough. And then over the appropriate study. Here in orthopedics, what we do is, she's worn her hands out. I said, thank you for doing that. What we do is related to bones and joints and muscles. And so basically those things show up on an x-ray. So one of the key factors that we use in orthopedics is an x-ray. And again, the young surgeons that I train, I try to train them, don't look at the x-ray first. Don't prejudge this patient. Because then you're going to try to be leading yourself and possibly the patient down the wrong pathway. Wait for that and then get the x-ray of the appropriate part that you found through the history and the physical examination. Knee arthritis, knee pain, swelling. Pain can be generalized, can be site-specific. It generally does not radiate. If they've got a knee problem, they'll point to their knee pretty much most of the time, if not all the time. This is an x-ray of a knee. Over here is a pretty normal knee, and this is a left knee with it's facing you. It can be confused. It may not be arthritis. It might be a meniscus tear, a cartilage tear internally in the knee. It might be tendonitis or bursitis, which happens on the on the knee, but not inside the joint. So there's a differential diagnosis there. Our diagnostic tests, again, the history, the physical exam, the x-ray. Okay, then when do we get an MRI? A lot of patients feel gypped these days because they read about, the quarterback for the, whichever team, he gets hurt on Sunday, and then he's got an MRI that night, and he's got, something the next day. Well, generally, they're looking for something else other than arthritis on something like that. They're looking for an ACL tear, meniscus tear, something like that. So MRI is not always indicated. In specific cases, it can be indicated. So we use that test judiciously. So basically, prevention of arthritis. A lot of your arthritis is based on genetics. If your parents had arthritis early, the chances are fairly high that you're going to get it prematurely. It can also be caused by trauma. If you injured your knee playing football in high school or cheerleading or doing anything else early on, there's a good chance that knee will develop premature arthritis at some point. It's not a for sure thing, but it's something to kind of keep in mind. The most important thing a patient can do, we have people from our comprehensive joint weight management program outside, and I welcome them and thank them for being here, because your body weight is a huge contributor to the amount of symptoms that you have in an arthritic hip or a knee. Every pound of body weight you put on increases what we call biomechanically the joint reaction force across your hip or knee by a factor of 3. So it increases the stress on your knee joint or your hip joint by 3 pounds if you put on 1 pound of body weight. And you can tell that kind of if you go down to the store and at a Long's or Safeway and you pick up a 10-pound bag of groceries, try to carry that up a flight of stairs. That's a lot. You'll be breathing hard, and it's a struggle. But if you put it on your own body, it's a very subtle process, and you don't realize that you've got that problem. A lot of times with people with arthritis, it's as simple as losing 10 pounds of weight. And if you have trouble doing that, we have the Queen's Comprehensive Weight Management Program. 90% of their stuff is non-surgical. You can drop the pounds. You turn back the hands of time on your joint. You want to stay active. Like I mentioned, cartilage is nourished by motion. Walking and swimming are the best. The joints, like the hip or the knee, don't really like jogging or running and things like that, because it's the pounding impact type of stuff is not really good for your joints. I have the hardest time with marathon runners that develop arthritis. I have to trick and switch them over to a different sport so they can get their endorphin fix. Stretching, yoga, Pilates, highly encouraging, because it's important to stay. As we age, our ligaments become tighter, our tendons become tighter, our joints become slightly stiffer. Those are great programs you should plug into something like that if you have any access to it. There's lots of them around. Supplements, they come in tons. All you got to do is go down to the drugstore. You see this giant row of supplements. The ones that actually work are glucosamine and MSM. And the studies have been done on all these, and they don't regrow cartilage. Nothing regrows cartilage, like I told you. But they will preserve the life of your cartilage. They're like a joint vitamin. They get into the joint synovial fluid, and they perfuse back and forth out of the cartilage. So they'll slow down the progression. In the treatment of arthritis, be it non-surgical or surgical, now I'm a surgeon, but I approach every patient from a non-surgical standpoint when I first meet them. My mindset is try not to operate on this patient. Okay, I dare myself. Just don't, if nobody wants surgery. Again, my young surgeons, they'll come in rushing into the room and say, hey, good news, you need surgery, to the patient. The patient goes, good news. I have to take them aside and go, no, it's not good news for the patient. It's good news. We have a fix for this, okay, if they need surgery, but it doesn't work like that. Most patients, good news is you don't need surgery. So what we try to do is go from the non-surgical treatment and exhaust what's called the conservative measures before we ever consider surgery. Our goals are two: relief of pain and restoration of your quality of life. We want to keep you active. Arthritis is an insidious process. You find yourself restricting. If you kept a daily log or a yearly log, you find yourself restricting your activities more and more and more. So if you look back 5 years, you go, wow, I used to do all that stuff. How come I'm not doing it now? It just may be that knee that's keeping you from doing that stuff. So modification of activity, you can find a different activity that doesn't hurt as much. You can take oral anti-inflammatories, the so-called NSAIDs, Aleve, Advil. There's various iterations of prescription type ones. Tylenol is a pain medication, but not an anti-inflammatory. And those can, they're sort of a very valuable treatment arm for the non-surgical treatment of arthritis. They do have side effects, kidney, liver toxicity and stuff, so those have to be monitored carefully. Use of a walking or assistive device, meaning like a cane. If you use a cane, in the movies, they'll always show you, at least 90% of the time, the patient holding the cane on the wrong side. You know, I don't know why they don't have consultants on this, but if they've got a bad knee on the left side, they're holding it, the cane on the left side with their hand and leaning on it. But what it's designed to do is go on the opposite side, because what it does, it shifts your center of mass in your body over about 6 inches as you're walking and takes the load off the joint. So that's, we can go into that more, but you don't need to know that. Just watch for that in the movies. Anytime you see them doing that, you go, okay, wrong. Cortisone injections are very, very helpful a lot of times. Okay, they're not dangerous to do. Studies have shown you can take this one. There's more mythology on this out there than you can shake a stick at. This is cortisone injection can be given into a joint, a particular joint, say the left knee, up to 3 times a year, every 4 months, without any side effects, without any deleterious side effects. You hear people say, oh, you can only have 1 in your life or 3 in your life or whatever that is. No, it's not true. But the problem is with cortisone is you cannot give it more than every 4 months, because it will start to deteriorate the joint faster. So if you have a patient, if I have a patient that needs a cortisone shot, it only lasts a week or 10 days, that tells me that that's not an effective modality for them in treating them. It's too temporary. It's too short a Band-Aid. So what they've done is they've come out with viscosupplementation injections, and these are legitimate. As you see it up there, it's a big word, viscosupplementation. Basically, you're talking about putting in a gel into the knee that stays in there for about 6 to 9 months and coats the joint. It doesn't work in everybody, and the way they discovered this stuff is from rooster combs. Believe it or not, how that happened, I'm not sure. And it's made of hyaluronic acid. There's 4 different kinds out there, but they're all basically the same. Hyaluronic acid is the main component of your normal body joint fluid. And what they do is they distill it and gel it down about 100 times more viscous. And so the surgeon will inject it into your knee in the office, just like a normal shot, and you do it once a week for about 3 weeks is the one that I use. And 50% of the patients approximately will be what we call responders to that treatment. And there's no way of predicting who a responder is going to be. Insurance covers this. And basically, if you're a responder, you know it within 3 weeks of the 3rd injection. All of a sudden, your knee just feels better. And it lasts anywhere, like I say, from 6 months to 12 months, somewhere in that time period. And patients will know the week that it wears off, the effect of it. And they just call up the office and they go, wore off last week. So you bring them in and repeat it. I've got some patients on their 8th and 9th series of these viscosupplementation injections, and prior to having this available to us, it was not, they would have a knee replacement, 7 or 8 years ago. And once you put a knee replacement or a hip replacement in, the clock starts ticking. It's a mechanical device, so it's eventually going to wear out, like anything mechanical. So you want it, we'll get to that in just a second, but you want, if you're going to replace a joint, you want to have exhausted every other possible non-surgical option, number one. Number two is you want to make sure that that patient has gotten up to the appropriate age where they understand. They may say someone's 40 years old and they've got a worn out knee prematurely. The only thing left for them is a joint replacement. So you're pretty much going to have to do a redo sometime in their life. So we do our primary surgeries now, planning for the next surgery. The good news is, and I'll get to this in just a second too, is that when joint replacements were first invented, the hip came first, the knee came second, and they lasted about 10 years. And now we're up to somewhere over 30 years of longevity in these joint replacements. That's a number you can write down. It's a long time. Try to find another mechanical device that lasts that long, and you'd be looking a long time. Arthroscopy for arthritis has not been shown to be effective if it's being done for arthritis, okay? Because you can't put new cartilage back in. So the problem is if you've got a piece of cartilage, though, that's torn, like a meniscus in the knee, and the knee also has arthritis, that's an indication for arthroscopy. That's the case where a patient that I would take and I would get an MRI of their knee because they're having what we call mechanical symptoms, intermittent sharp pain localized in the knee. Get the MRI, and lots of patients out there, I never operate on an x-ray. Just because your knee looks bad, I want to know how it feels. How does it perform? That's the important thing. Stem cells, PRP injections, lasers, prolotherapy. Prolotherapy is basically a washout with saline fluid. These are being touted. I read about them in the newspaper all the time. I hear about them from patients. They come in and ask me. They say, I heard about this. How about this? Because nobody wants an operation. I think Bobby, my patient, will come up and tell you his version of what his mindset is, and you guys will probably, more likely than not, identify with him. Because he'll give to you from a whole different standpoint than I can do it as a surgeon. These therapies, and I cannot stress this enough, stem cell, PRP is platelet-rich plasma. They take some of your blood out, they spin it down in the office, and then they get they pull the top part of it off and they re-inject it into you, into the joint. And prolotherapy, like I said, is washing the joint out with lactated ringers or saline. Those things do not work. They're not ready for prime time. There's still work. Stem cells are in the future of everything in medicine. There's no question about that. But the AAOS, which is the American Academy of Orthopedic Surgeons, which is our biggest organization that gives us our credentials. I'm a fellow of the AAOS, or the AAHKS, which is even a more select group of orthopedic surgeons it's the American Association of Hip and Knee Surgeons. They do not condone the use of these modalities. There's guys out there using them. Is that ethical? I don't have an answer for that. I'm not going to judge them. I'm just saying that there is no scientific proof. There are no randomized double-blinded controlled studies that show that those are effective. You're going to meet people who say, my friend, my cousin had this, and he swears by it. Good for him. But I'm here to tell you from an objective scientific viewpoint, no, they don't work. Okay, so the treatment, keep the body weight down, we talked about that. Stay active, low impact exercise daily. You should do something every day of low impact. It turns out plain old walking is one of the best things you can do for yourself. You want to go out and go a distance, you can go about 15, 20 minutes. That seems to be the magic number for all kinds of exercise, cardiovascular benefit and for joint benefit. First, you're going to see your primary care physician, maybe a rheumatologist, but more likely your primary care physician. They're going to start all this ball rolling for you as far as the diagnosis goes. When they refer you to somebody like me, you're thinking, oh man, it says orthopedic surgeon, uh-oh, going for an operation. Not my office. You're going to come in, I'm going to hear what's going on with you, and then we'll try to figure out a way not to operate on you, like I said. Physical therapy, does it have a place? Well, if a joint's arthritic, if it's worn out, there's a toss-up here. You're trying to make a joint move that's already arthritic and it's going to hurt, but you want the muscles to stay strong around the joint. So we've studied a modality called prehab. So if we're going to do a joint replacement on a patient, we're leading more and more towards sending that patient to a couple sessions of physical therapy before we take them to the operating room to get their muscles trained so they'll recover from the operation faster. We'll talk about that too. We want a main thing, exhaust all conservative measures first. We're going to have to do carpal tunnel releases on both these ladies here for their median nerves. Thank you for doing this. The surgery, scary as it may be, is basically the cure for arthritis of the hip or knee. What we're doing is taking an arthritic hip or knee and we're changing the surfaces with inanimate but state-of-the-art surfaces. The bearing surface today for a hip is a ceramic ball and a highly cross-linked polyethylene socket. The outer parts of those are titanium, 100% pure titanium. That's the state-of-the-art hip replacement. We're basically replacing the joint with artificial surfaces. We do this in a very specific way so as not to disturb the major muscles and tendons and nerves and blood vessels around the joint, and so the patient has a faster recovery. But it's virtually a miraculous surgery. It gives you back your quality of life. It relieves your pain 99% of the time. It does not eliminate your pain. Everybody has pain. That's God's way of letting you know you're alive. That's one of those things, And so you wake up, yep, my shoulder hurts today. Okay, it's not a good day. We're good. Let's roll on. Okay. This is an example right here of a partial joint replacement. This is a partial knee replacement. You hear about those. Okay? And there are very specific indications for this. Only one part of the knee can have the arthritis. The other part has to be not worn out. And so you put a partial knee replacement in, and this is probably makes up 10% of knee replacements or less. Most joints, and they don't last as long as total knee replacements because the biomechanical forces are such that they tend to wear earlier. But they're good in select indications. Okay, the goals here: relief of pain, restoration of quality of life. So hip and knee replacements, they've been around for over 40 years, both of them. The hip replacement, the modern day hip replacement, was invented in England, Wrightington, England, by Sir John Charnley in 1962. He called it an LFA, a low friction arthroplasty. And what he did was, in England, they have very few attorneys, evidently. Okay, so he had a shop in the back of his hospital, and he would go out there with one of his mechanical engineers, and they would come up with these devices, and they would go back in the hospital, and he'd get patients to sign consent forms, and they would put them in. He started initially doing people over the age of 80. And he used cement in all of his hip replacements, and he perfected this technique. And for that, he was awarded knighthood in the British Empire and also the Nobel Prize, and rightly so. To this day, everything we do in hip replacement surgery is based off that 1962 discovery or development. About 13 years later, in 1975, John Ensall, also an Englishman, but working in the Hospital for Special Surgery in New York City, he developed a modern-day knee replacement, or total knee arthroplasty. And what that is, it's not like a door hinge. It's got three parts, an upper, a lower, and a kneecap part, and basically those parts work independently but together in concert so that your knee not only flexes and extends, but it rotates, it has enough play in it to replicate the kinematics of your normal knee. That, again, over the years has been developed and refined. Lots of times, like most things, even in automobile industry, the tangents go off here and there. As surgeons, we are trained not to don't fall for the fads, we say. Okay, don't take a bite of this thing. This is the latest and greatest thing. Make sure they've got data. Make sure that these things are going to be safe for patients. We are your advocate, basically. We're the translator. We're the internet filter. You go online these days, it's crazy. I mean, you look at stuff and you'll make yourself nuts within about 15 minutes looking up whatever you have wrong with you, because there's so much misinformation. 90% of the stuff out there is misinformation. So What patients used to come in, they say, okay, I have a couple questions about my surgery. And I say, okay. And they pull out and say, how long will the operation take? How long will I be in the hospital? And is it painful? Okay. I go, okay, easy. Now they come in with their iPad, and they go, I have a couple questions for you. And they go onto a couple websites, and you go, oh my God. And I tell my nurse, uh-oh, we're in trouble here. So basically, my job as an orthopedic surgeon is to be your internet filter, is basically to educate myself so that I can educate you and give you the best thing. I don't work for any company. I've assiduously avoided being a consultant for a company or an implant company, for example. I work at Queens, but I'm the medical director. My job is in private practice, and what I do there is free from as much as I can from any influence of an outside agency, so I can pick the best thing for the patient. What I use in my patients today is what Bill Gates or Jeff Bezos or somebody like that, a billionaire, would come in, would be able to get, because that's the best there is. If they said, I'll give you $10 million, give me something better. Sorry, can't do it. Well, I'm using the thing that I would have put in me. And I look at the data, and I go to national meetings, international meetings, find out what the best stuff is, and that's what all my patients get. You need to have your total joint replacement performed by an experienced surgeon in a major medical center. Our success rate's extremely high with these, okay? There's a lot of doctors out there, a lot of orthopedic surgeons who are not specifically fellowship trained in joint replacement. I can't stress this enough. Don't be afraid to ask. Did you do specialty training, in joint replacement? I learned so much in that extra year I did at USC, I couldn't believe it. I thought I knew a lot when I went in, and we did 1,200 of these in a year. And it's amazing, and I continue to learn to this day. I try to keep up on stuff because it's so important to have this done by somebody that does it well. Because a third of my practice, to be candid with you, is actually fixing stuff that was done elsewhere. Unfortunately, patient has a primary knee, or primary means the first time, has a knee joint replacement or a hip replacement, and it didn't work out so well. So they come in with a stiff knee, a painful knee, a hip that's not stable. So I do my best to figure out what went wrong and try to fix that. So I wish that number was 0, but it's not. So be very judicious. When you want to find a surgeon that listens to you, that talks, just like anything else. But it's super important to develop a two-way street of trust with that surgeon. Like I said, 30 years was what we're looking at number-wise now, these things lasting. Quite a long time. And we put them in today with the idea of being able to redo them. Now, we're planning the second operation already. We're not burning bridges behind us. When I first started practice, they were still in the early phases of doing hip and knee replacements. So I was seeing people that everything got used up, and you have to be able to attach these components to stuff, and the bone all got used, and so we had to get pretty creative back then. Now, more and more surgeons are sparing muscles and ligaments. At the Queens Medical Center, why is this place, why am I working here? That's a good question. Why do I do my joints here? Well, it's pure and simple this. This is the #1 rated hospital in the state of Hawaii. If you get in a car wreck, this is the only level 1 trauma center in the state. Everybody else is okay. You don't want to be okay. It's kind of like the commercial. Okay just isn't okay, This is the best hospital. The other hospitals are good. Queens is better. This is the Queens Medical Center. It's one of the highest ranked hospitals in the country. As a matter of fact, it's the first and it's the only hospital in the state of Hawaii with what's called advanced certification for hip and knee joint replacement, given out by the Joint Commission. Now, the Joint Commission is a national organization. We call them the hospital cops. These guys come out every 2 years, and they inspect the hospital from top to bottom. From Chicago, they come, and they are ruthless. They go through every little thing, and they quiz all the nurses, everything. They're looking stuff. They're like Marine drill sergeants going through and wiping for dust with a white glove. I mean, it's that rigorous. We managed to get our initial certification 4 years ago. We got our advanced certification, one of the first 50 hospitals in the United States to get it, and we got our second advanced certification this past year. We did so well with a team that was surrounding me. It had very little to do with me. It had everything to do with our physical therapists, our nurses, our techs, all the personnel involved in this process, and the hospital itself, working as an ohana, as a team. That the Joint Commission, you never really want to. It's kind of like the IRS. You never want to get a letter or a phone call from them. You never really want to hear from these guys because it's almost always bad news. They sent me an email and said, we'd like you to come back this past October and be our keynote speaker in Chicago and tell the rest of the people from the other hospitals in the country how you guys did it. How did you achieve this? I thought it was a prank email. I thought, sure, this is like somebody is BSing me. This is like, so I wrote him back. I said, is this for real? You know, and I called the number and all that stuff, and it was for real. It was amazing. And so people pay attention to us out here in our little remote outpost in the Pacific. It's legitimate, but it's important to have a team put together that does it in the very, very best way, what we call best practices, because patient safety and outcome is the goal. Our orthopedic surgeons, likewise, are the best trained and most experienced in the state. They make up the preponderance. And when you get Honolulu Magazine, open it up, and you look at 90% of the orthopedic surgeons listed there, their home base is Queens. For total joint replacement, we use the finest implants available, the safest surgical techniques. It's critical that the surgery be done right the first time. We avoid the hype of the fads. Okay, 15 years ago, the minimally invasive total knee was the big thing. It was, oh God, get your knee, it was minimally invasive, small incision. Well, what happened is we found out very rapidly that the smaller the incision got past a certain point in the skin, the surgeon couldn't see anymore, and then the complication rate started skyrocketing. You got to be able to, 100 years ago, Halsted, one of the fathers of modern general surgery, he said, exposure is the secret to good success in surgery. Okay, so make your incision big enough. If you cut the skin 6 inches long versus 3 inches long, it takes exactly the same amount of time to heal because it heals side to side, not end to end. So if you were to have an incision made on you, you couldn't tell how long that incision was unless you looked at it in the mirror. But you can tell if your joint isn't working right because they couldn't see what they were doing. It's important. We use what's called muscle sparing surgery. So we try not to. The only surgeon, and don't buy into this no muscles are cut thing, okay? The only people that don't cut muscles are dermatologists, basically. They're cutting through skin because everything in your body's got muscles somewhere underneath it. So you have to cut small muscles, but you cut them the right direction, you spare them, you move them away out of the side in order to do a joint replacement. But you want to do as little as possible cutting of those and making your exposure. The complication rates otherwise can be extremely high and the results often inferior. You want the best chance possible to get an excellent result. I was taught long ago that if a patient comes into you and their primary concern is how long is the incision going to be, they're not ready for this operation. The question they need to be asking is, can you make this pain go away? Can you give me back my quality of life? Can you make it so I can enjoy things again? The answer to that's yes. You know, if I make an incision on somebody, if it says it's going to be 4 inches long, and they come back with a ruler and say, you said 4, it's 5. I measured it. I go, yeah, but you're walking. Yeah, but it's 5 inches. You go, oops, don't make that mistake as a surgeon. Robotic surgery. I'm getting toward the end here. So robots, sounds good. Robots, man, they got to be better than us. Well, they're not, as it turns out. This randomized double-blinded studies between surgeons with robots that are experienced surgeons versus robots, there's no appreciable difference between the best robotic system out there. Sounds good, more precise. But orthopedic surgery is very much a mechanical art, a technique plus an art. You have to be able to look at this thing. I'll tell you an example. When the robots started getting some popularity, I went back to a robotics course and I watched the surgeon do it. I was in there with him. And he's got these optical sensors drilled into the bones, and he's doing it on the patient. He's got a tech over here with a computer. It's reading out angles and all this fancy stuff. And he's getting the component right into a position. He wants 25 degrees, and the tech is going, it's 23, 24, 25, perfect. He's holding the thing like this, ready to do his drilling, and he goes like this, 25? He goes, yep. He goes, moves it like that. I said, whoa, what'd you just do? He goes, well, it didn't look right. I said, but it said 25. He goes, yeah, but it didn't look right. And he was right. Because so you can get yourself in the ballpark. Robotics are good for surgeons who are learning. It's good for us teaching our young residents here, teach them techniques and stuff like that. It can keep them out of trouble. But for an experienced surgeon, robot doesn't help. It doesn't make it any faster. In fact, it can make it slower. Anterior versus posterior approach. Surgeon, yeah, did you have your surgery through the front or they go through the back? The anterior approach for total hip replacement was popularized by a surgeon by the name of Joel Mata at USC about 20 years ago. He was a trauma surgeon, and he decided he got tired of doing trauma, so he started doing hip replacements. Matter of fact, in my fellowship, I used to run into him. He would operate in the operating room right next door to us. Fabulous surgeon, very technically savvy. And so he developed this anterior approach coming from the front, and people talked about no muscles are cut, it's a faster recovery, it's got sold as a hype. And some of the other hospitals here around town were hyping that approach. Okay, the fact of the matter is, in the latest meeting I went to in Dallas, Texas in November, the studies have shown that the results of an anterior versus an approach from the side, posterolateral approach, are identical. The results short term, the recovery is just as fast. We get patients up within 3 to 4 hours of their operation, fully weight bearing on their joint, and the recovery and the longevity are identical. The pain levels, identical. So if you are intent on wanting somebody to go in from the front, don't let somebody tell you it's better than going from the back. But you want to find out if that surgeon, his experience is from the front, then let him do it from the front. If you go to another surgeon who says, I do it from the back, make sure that's where his experience is, let him do it that way, and rest assured that your recovery is going to be identical, and it's good. At Queens, your surgery takes about 2 hours. Patients come in and ask me, how long is my surgery going to take? Remember that little paper they pull out of their pocket? How long is the operation going to take? My answer to them, and it's a true answer, is till I get it perfect. That's how long it's going to take. As perfect as I can make it anyway, unless you want me to stop sooner. You know, yeah, right, the same response. Yeah, no. Take your time, take your time. But a ballpark figure for the families in the waiting room is we tell them about 2 hours, something like that. But we're not going fast. We're going precisely. That's the important thing. Everybody's a little bit different. Nobody's identical. So every case throws a little bit of a curveball at you. That's why you want to have an experienced surgeon doing this, and you don't want to be part of an assembly line process where you're the fifth case or sixth case of the day for that guy, because people tire out. Surgeons tire out. Their attention span starts to drop. Okay, but you should be up walking within 3 or 4 hours. Our physical therapists, we keep track of this, they're up within 3 or 4 hours. Some patients are even going home the same day as their surgery now. We have a thing called AROS, which is Enhanced Recovery After Surgery. That's what that acronym stands for. It's early mobilization, gets you up fast. We found out it lowers the chances of blood clots, pneumonia, urinary tract infections. We don't even put catheters in people, bladder catheters anymore. You're not tied to the bed, you're not tied to an IV. Very little intravenous medications except for intravenous antibiotics for 3 doses after the operation. You're eating your food, you're fixed. You're up walking. You're taking your medications orally, not intravenously. We do what's called multimodal analgesia. The anesthesiologist will put nerve blocks in around the joint. We, as a surgeon, intraoperatively, before we close up your hip or your knee, we inject it up with a long-acting anesthetic, which usually lasts 48 to 72 hours. So that initial pain that you have with these, and after 72 hours, the body has modulated its pain response down quite a bit, so you're not really hurting like you were before. Adjunctive medications, we give these pre-op now as a loading dose an hour before you go to the operating room, and so when your pain response, even though you're under anesthesia, your body's experiencing pain subconsciously, so that modulates that whole response. And we have minimal post-op nausea the way we do anesthesia. So pain relief with a total hip is virtually immediate. Patients wake up and they go, wow, this is amazing, I feel so much better. Knees are a little bit of a different animal. We're getting closer on that, but we're not perfect at it. They're a little more sore, but not anything like they were even 10 years ago. And then again, the beauty of it is with arthritis, your joint gets worse every single week or every month. With a knee replacement or hip replacement, for a period of a year to 2 years, it gets better every week and every month, and then it achieves its steady state of performance, and it stays there. After surgery, your therapy length of stay is individual. Some guys say, we do them all as outpatient. You can't do everybody as an outpatient, get them home the same day. You can't. It's not safe. It's what's about safety for the patient. Some patients, probably 30% of the patients or so can be sent home the same day. 70% of the patients cannot safely be done so. They have what are called medical comorbidities, high blood pressure, other things, diabetes. You've got to keep them in a hospital in a safe place. And this is what I do as the medical director. I make sure the patients are safe. That's one of my jobs. I'm a safety officer. And so if you need to stay one night, if you need to stay 2 nights, if you need to stay 3 nights, then if you go past about 3 nights, and it's rare for that to happen these days, say you haven't got anybody at home to help you, then we'll get you over to Rehab Hospital Pacific for a stay there that insurance also covers, so until you get independent enough to go home. But surprisingly enough, about 80% of our patients are ready to go home by the first day post-op. Every step in your recovery here at Queens is monitored by a very highly trained team of nurses and case manager, and we also have what's called a nurse navigator. That person, that nurse, his name is Chris Bautista. He will follow you from the pre-op area all the way through to your discharge, and also will call you at home and make sure you're okay. He's checking on how your therapy's going. It's like having a guardian angel by your side to help walk you through it. I cannot overstress the importance of this. This is one of the features that impressed the people in Chicago at the Joint Commission. So our goal here, to sum up, is to restore your mobility, relieve your pain, and allow you to remain independent, live a quality of life. Your health, without question, is your most valuable asset. Not wealth. Health is it. It's critical you make the proper choice in choosing your surgeon. Be picky. Interview people. Don't be afraid to get a second opinion. You should have the right vibe when you walk into that doctor's office. You should feel right. You should look right. His staff should respond to you. They should answer the phone. They should respond to your inquiries. You shouldn't feel rushed ever. And you should have a feeling that that surgeon truly cares about you as a person. That can't be faked. Okay? It's crucial that you choose the right place to have it done. Queens, in my opinion, is the best in Hawaii. The take-home message here is there is an ultimate cure available for hip and knee arthritis. That is the good news. Okay, when our residents come in and they say, hey, we got some good news for you. Well, the good news is that there's a cure for this. There are other things that are still uncurable in medicine. But hip and knee replacement can be fixed. And if it comes to the fact that the conservative, non-surgical methods are not effective, this does work. It will restore your quality of life, allow you to retain your independence. Mahalo. Sean's going to talk to you about just a second about my patient here, and so I kind of gave him a little intro, but this guy's a special guy. So go ahead, Sean.
So the second part of our program tonight is we're going to bring up a patient who's going to tell you his experience. He's 85 years old. His name is Bobby Hoffman. All I was told was that Bobby's coming is going to share his story. Bobby had a total left knee replacement in 2006 and a right total hip replacement in 2007. I'll let Bobby tell you his story because I was going to tell you a little bit more, but he got upset. So I don't want to steal his thunder. So Bobby, why don't you come up and talk a little bit about your story?
Good evening. As you were told, am a knee replacement, hip replacement patient of Dr. Kane's. I'm very grateful to the late Dr. Richardson, who at the time I was to get my knee replaced, he was the one that recommended me to see Dr. Kane, and I'm forever grateful to him for that. Now, if you've ever been to the Kane Institute, you'll know, well, I have a name for it. The Kane Orthopedic Institute Trio. Now, they don't perform. They're not going to sing and dance for you. It's not that kind of a trio. They are a team. And 1/3 of the team is Dr. Kane himself. And I would be remiss if I didn't mention the other 2/3. That would be Wendy and Jane, two lovely ladies who go about their daily tasks in a very, very professional and efficient manner. And at the same time, they have a wonderful personality that creates a warm and friendly feeling in that office, along with Dr. Kane. And you should know something else about Dr. Kane. He also happens to be an excellent diagnostician. I know because on several occasions, I would be there for a simple review of what was going on with me, and I brought up the fact that I was troubled with some kind of a health issue. Put me up on a table, examines me, and boy, within no time, he comes up with the correct answer, which I found out from the doctor he sent me to. He hit it right on the head. He did that a few times. I get the name of the physician. If it's not his particular expertise, I get the doctor who can do it. And one time, Jane even made the appointment for me. So when I go now, or have been going for some time to see them, it's not like I'm going to see another doctor. It's more like I'm going to visit family. They know that because I told them that. And Dr. Kane is also a person who just doesn't treat somebody who comes into their office, another person with a problem. No, instead, he takes a personal interest in everyone that comes into that office. I know. I've known him for 13 years. And now it's 13 years with the knee, 4 and 12 with the hip. And you just saw, I walked up here without any assistance. I've been walking on it, except for a few times when I explained to you. And I'll be 86 in 3 months. So, God bless senior citizens. I first had an incident on January 2nd, 2015. I'm in Thailand. I'm crossing the street. I'm walking in the pedestrian walking lane. But the Thai people, drivers that is, they do not pay much attention to traffic rules and regulations or any kind of thing of that nature. They're more like they're involved in the Indy 500 race. I found that out because when I got halfway across this street, I got slammed on the right side. Now, it also felt like somebody had hit me over my right eye with a hammer, and everything went black. The next thing you know, I'm flat on my back in the middle of the street, bleeding profusely from my right eye. Also, both of my hands have no skin. Both of my knees have had the skin removed, and my elbow as well. I'm lying there. I look back at this vehicle that's sitting there. It's a Toyota SUV, a white Toyota SUV. And I'm not just dropped in front of it. I'm about 6 or 7 foot in front of it. So I knew during that period of time, when everything went black, I must have gone airborne because I wouldn't have gotten that far away from that vehicle if I didn't. I was helped to my feet, put on the sidewalk by tourists because this happened to be a heavily tourist area and the tourist police were there. So they immediately called, an ambulance came, took me away, and the guy who hit me, a Thai native, was taken to the police station where he had to write an accident report indicating that he was definitely at fault and that he didn't stop, but he hit me in the pedestrian walking lane. Now, I don't know what happened to him insofar as legal action, but I do know one thing. He had insurance, and I was grateful for that because it paid for the whole bill. Now I'm in the emergency room. Somebody tells me, the one who's stitching you is a plastic surgeon. I was happy to hear that. Next thing you know, I'm in intensive care. I got these rolls on either side of me, so I can't roll the other way, and I'm wearing a neck collar. Doctor comes in and says, you have no broken bones. You have a fractured neck, but you have no broken bones. And he said, it's quite unusual for an 80-year-old person to not have brittle bones. So he says, they'll heal by themselves, these fractures in your neck, but you have a blood spot on your brain. And you'll have to wait until that goes away, or you won't be able to fly. Time passes, blood spot goes away, I'm able to fly back. I get a ticket for the next day. Before I leave, I call Dr. Kane's office, make an appointment, so that I can see him immediately when I get back. I go there, get x-rayed, go up and see Dr. Kane. He put those 2 x-rays of my knee and my hip, and don't forget, I was hit with a moving vehicle on the right side. That's where the hip replacement is. And I crashed down after I went out, and thank God I went out, and came back from being blackened out. Otherwise, I wouldn't be here speaking to you. And it's happened many times in Thailand where people are injured for life or killed. He puts them up on the wall and he says, these x-rays are exactly the same as the x-rays that were taken of those replacements on the days that I put them in. I said, that can't be. I got slammed on that side, and I flew through the air and hit my, you're okay, nothing wrong. So let's fast forward now. Let's go 10 months, October, same year. I'm walking in Ko'olina this time, I'm in Hawaii. And I'm walking out past lagoon number 4. It happens to be a dirt path. And as I'm going, I've kicked a few rocks out of the way because I don't want to step on them, lose my balance, and fall. So I see one out in front of me as I'm approaching it, and I'm walking rapidly. I give it a good swift kick, expected to see that rock flying. Nothing. It didn't go anywhere. It was more like an iceberg. And that was not a surface rock. It was just the tip of a rock. The rest was underground. When I kicked that thing, my right foot, right leg, and my whole right side stopped. But nobody told my left side about it. And it kept going. I was airborne. Again, this time I wasn't blacked out, so I saw that ground coming up at me. Well, I struck my left knee, left arm, and this time, so I wouldn't be impartial, I cut over my left eye. Now, I figure, well, I got to get up. I got to get out of here. So I stand up. It's painful, right in my left groin. So I look around. There's nobody. There's even no people fishing, as they usually are out there on the rocks. So I know I've got to get up, and I do. It hurts. I got pain in my left groin. I got to get out of there. I have no phone. I walk about the distance of a football field, about 300 feet, holding my left side. I get to the car, sit down, no pain. No pain whatsoever. I was in excruciating pain while I was walking. Now, nothing. So I'm saying, well, I guess I just pulled a muscle. Because now that I have no weight on it, It doesn't bother me. So I go to my home, try to get out of my car. Different story. The pain is back. So I step out of the car, and that struggled. Now I'm holding on to the hood of my car. I try to make a left turn and step out between the two cars. That leg does not move. I got a shot, a real hard pain right in my left side. Two neighbors saw me, and they came over and assisted me to a chair that one of them had brought out. I'm seated in the chair, and again, I don't feel anything. There's no pain. But she says, I'm calling an ambulance. You're going down to emergency. Ambulance comes, I go to emergency, I get x-rayed, and now I'm sitting in a bed in a hospital. No pain. And I'm waiting for the doctor to come in with the report of the x-ray. He comes in, and before he could say anything, I say, well, I guess I really pulled a muscle this time. He said, you didn't pull any muscle. He said, you fractured your pelvis. So I said, well, I can't imagine I was able to walk that way. But I guess, the shock, the adrenaline, the boost of adrenaline, if you get that boost, and also God helped me get to the car. So now I got to go through a month of physical therapy in the pool at physical therapy. Nice warm water. Within a month, I'm okay. But right away, after this happened, I make an appointment with Dr. Kane. Up with the x-rays, looks at them again and says, both of them are exactly the same as they were 10 months ago when you were hit by the vehicle. No change. And I'm beginning to think now that I must be a walking accident looking for someplace to happen. So let's fast forward now to 8 months, May 2016. And it's May 1st, and I'm 19 days from my 82nd birthday. I'm walking again, but I'm not walking in Hawaii. Actually, I'm in Lhasa, Tibet. What am I doing in Lhasa, Tibet? Well, for many years in magazines, I had seen photos of this magnificent palace. It's called the Patala Palace. And I said, I got to see this place. So I got on a tour with 8 other people, and I got there, standing there, and the Sherpa guide, he knew how old I was because he had all the passports of all of us. He says, look, this place has been here since the 14th century. It's built right into the side of a mountain. And it had 1,000 rooms with 1,000 monks, including the Dalai Lama himself. And by the way, this current Dalai Lama happens to be the 14th Dalai Lama. Little trivia. And so he says, in the 14th century, there were no elevators, so we're going to have to walk. So up we go. And with the exception of stopping to take some photos, or for him to stop and tell us about some points of interest, we get to the top. We get to the top, and he tells me, folks, you just walked up 272 stairs. Now, he doesn't know, because that's cool. I got jeans on. He can't see the scar. He doesn't know I've had left knee replacement, hip replacement. He has no idea I was hit by a car 16 months before, or that I had fractured my pelvis 8 months before. So he felt surprised that a person my age could have done what I did. And I was right behind him all the way up. So now it's 4 days later. It's May 5th. And we are now, after traveling in the area, seeing all different pagodas and things, we are now outside of the city of Kathmandu, Nepal. And I have just finished walking up a steep incline, very slowly, taking baby steps, deep breathing, and I get up to the plateau, the level where the rest of my tour is. And I am standing, as I said, at 8 o'clock in the morning, 0 degrees temperature, no oxygen, at 17,600 feet at the base camp of Mount Everest. So, in a sense, you could say, well, I guess you really did put these prostheses to a test. When I was up there, the people I was with came over and congratulated me because they knew I was the old man. There was also a group from Japan, young college students. They came over, and they were saying the same thing, congratulations and everything. And I thought probably at least one of them, as they walked away, would have said, this guy's as old as my grandfather, and I don't expect to see my grandfather up here. So I want to let you know, in conclusion, that if you're about to have any replacement surgery, 2 factors keep in mind. One is yourself. You're the one that has to do the work. The surgeon, he puts it in. You got to make it work. It's got to bend, because when you come out of surgery, it's straight. So you have to do exactly, you got to commit yourself. You got to make a commitment and dedicate yourself to saying, I will get this knee to bend. Or if it's your hip, get that to work again. And if you neglect it, if you say, oh, I'm tired tonight, I think I'll do it tomorrow. Oh, I got something else to do, I'll do it tomorrow. It's going to extend the time of recovery. I work diligently at it. They will tell you, Dr. Kane, and the physical therapist will say to you, you have to do so many repetitions, so many times a day, and you better stick to it and be faithful to it if you want to make a quick recovery and be able to walk again, go upstairs again, and if it's your knee, you want to be able to bend that prosthesis knee as far as you can bend the knee you were born with. The second factor, and the most important factor, is you've got to find yourself a surgeon who has the knowledge, background, and the years and years of practical experience of putting in these doing this replacement surgery successfully. And you want to be sure then that you get it done right the first time. And that's why my surgeon and my very good friend is Dr. Thomas Kane III. Aloha. Mahalo nui loa.
Wow.
Still there.
I'm told Dr. Kane, I'm sorry, Bobby will be signing copies of his autobiography outside
no kidding, right?
afterwards for about $20 each
Wow.
if you were interested in hearing more of his stories.
Yes, for sure.
So folks, we have about 15 minutes left. I know you folks heard a lot of good information. I want to give you folks a chance to ask any questions of Dr. Kane and Bobby here, both who are free to answer any questions that you have. So let's go ahead and get it started so we can get as many questions in as possible. Go ahead.
These on test? Yep, we're on. We're live. Go ahead.
Thank you very much, Dr. Kane,
Sure.
for sharing this very interesting information. I most enjoyed your advice to young doctors, and I just wish more would follow it. But, on a personal note, I've had my left tibial plateau fractured and reconstructed, of course. And in reference to the replacement future that I may have, I assume that it's going to occur before my right one because of that surgery. So in light of that, it's very good advice on what to do to keep from getting these surgeries. But is there anything that I should be doing extra for my left knee versus my right knee?
The right knee is the one that got fractured?
Left.
The left did. Okay. So basically, that's a great question, and thank you for the compliment too. Appreciate that. If you get a knee joint, for example, traumatized like you did, it predisposes it to premature arthritis, as I alluded to in my talk. The degeneration of that joint is not 100% predictable. So somebody with a crystal ball will say, it's like that old line they say, well, the doctor told me I'd never walk again, and here I am today, kind of thing. I mean, I try never to make those kind of predictions. If you want your knee to last as long as possible, I would advise you to do a combination of stationary bike riding, elliptical exercise, and walking, and swimming. Those are the 4 big exercises that I recommend. What you want to do is what we call cross-train. You want to do one day, then the next day. You don't get bored doing it that way. So many people I've seen, they buy themselves a stationary exercise bike, and it becomes just an expensive clothes hanger sitting in the middle of the room. And eventually you can't even find it anymore. The big thing on TV now is these Peloton bicycles. You see everybody just jumping on them, they're yelling, and they get the instructor that's like hopped up on some kind of crystal meth or something, trying to get people to do stuff. It's like, no thanks. But if you get yourself a program that's reasonable, that you can follow, 20 minutes a day is enough to do it, and do it consistently and vary it up. You want to keep your weight down. You look plenty trim enough to me, so basically you want to have your body mass index. We have a rule here at Queens: if your body mass index is a combination of your height and your weight is greater than 40, I don't allow that surgery to continue, because statistics have shown those patients get complications. So we have ways of getting people's weight down under the right number, and then getting the surgery done with the best possible results. So what I would do is plug myself into, if your PCP is not quite comfortable with taking care of you, get yourself plugged into an orthopedic surgeon that doesn't have the surgical mindset, that monocular vision, trying to get you to the operating room. Somebody's concerned about, Bobby will tell you, he hasn't, the other knee that I haven't replaced, when he's had bounced around at Koolina and Thailand and things like that, we're treating that conservatively, right? Good. So cortisone shot every once in a while, anti-inflammatory medications. He keeps himself in amazing shape. I mean, I'd never be able to do the stuff he can do. But you want to keep yourself as fit as possible for as long as possible. When the time comes to needing your knee replaced, that operation, having had a previous tibial plateau is the top part of the shin bone right at the bottom of the knee joint. Those require specialized attention in fixing those, because it's not a virgin knee. And so you want to have a surgeon that's experienced in doing that kind of stuff, and kind of like I was alluding to. Because what we have is an array of specialized implants that substitute and make sure that bone is reinforced so that it'll perform for you right after. Does that answer part of your question?
Not exactly. So
Go.
What should I be doing more for the injured knee that I'm not doing for the virgin knee?
The injured knee is going to be, by the nature of having been injured, is going to be a little bit weaker than the other side. But that's why God in his wisdom gave us two sides. So basically the right knee is going to be its buddy. And so it takes it along for the ride. So if you're doing elliptical, the other knee is getting stronger too. You don't have to focus on that knee and do twice as much for the other side. Just try to balance it between the two. People I see that are athletes, when they're cross-training and stuff for collegiate sports and high-level performance, they get themselves hurt when they're doing these things, single-legged stance stuff. That's all looks really fancy, and stuff when you watch it being done, but it's not good for you. Your body's a symmetric organism, and it likes to do things symmetrically. It gets hurt when it's off balance. So you want to have, it's a good idea to go to a physical therapist, and your doctor should be able to send you to a qualified one. And they're like personal trainers. Insurance will cover that for like 6 visits or 8 visits, just for and learn how to get trained by these people. These people really know what they're doing, the good ones. And you can call my office. My nurse Wendy's back there, and she can give you. We can direct you that way to a physical therapist. And that's a good way, because like the Hollywood stars all have personal trainers. We're all envious of that. Gosh, I could do if I had a personal trainer. Well, the way to physical therapists are essentially personal trainers. It's a good thing to have. And so you've probably been plugged into one since you hurt your knee already. So if you didn't like that therapist or didn't feel like quite connected, we've got ones that we like and we recommend. The pool, Bobby mentioned, yes, absolutely. Pool therapy is huge, right?
Oh, yeah. Fantastic. I made a recovery just like that.
Okay.
Thank you.
Any other, next question, please?
Yes.
Go ahead.
Thank you, Dr. Kane.
Yeah.
I'd like to ask you, I have osteoarthritis in my knee,
Mhm.
and the surgeon suggested that I do surgery on it. But my PCP just retired, and I saw a new one, and she said, you shouldn't have knee surgery. You walk okay and everything. And so I'm kind of now going okay. But you mentioned the visco supplementation.
Right.
If I do the visco supplementation, would that prevent, I mean, is that like not having that big old knee surgery scar and prevent it from?
That is a great question. Nobody wants surgery. None of us. I don't want surgery on me, if at all possible. The viscosupplementation works in about half the patients that we give it to. The other half can't tell the difference, so they would call them non-responders. But if you have a chance, a 50-50 chance of being a responder with no downside, that's the way to go. So if I would definitely try viscosupplementation. You can call my office, or you ask your PCP to refer you, and you get, the shot is not very painful at all, and you walk right out of it. You don't have to modify your activities at all that day. You don't have to be down. There's nothing special. You just walk out. And if it's going to work for you, it works about 2 to 3 weeks after the third shot. So 1 shot a week, once every Monday for 3 weeks, and then just see how it does. You'll know it's not subtle. When it really works, then there's no downside to it. And if it lasts you 6 to 9 months, you're the one that has to decide what quality of life. Only you can do that. Like Bobby alluded to, it's not somebody else's decision, it's yours. But you have to be able to be presented with the options, and then basically you can make an informed decision based on that. And that last option of surgery is scary. Were you scared about your surgery?
Very apprehensive. I've never had surgery like this before. Prior to this, the only big surgery the only big surgery I had prior to this was I had varicose vein surgery on my left leg, but that was back when I was 40. I had never had something. I was very apprehensive. I heard stories. Some of them were not so good. It was about people complaining that they had the surgery done and they still weren't able to walk without pain. That didn't happen to me. I've been walking without pain. And also, I didn't say it before, but the left knee was done. But the right knee, Dr. Kane said, you got another 6 or 7 years. That was 13 years ago. I'm
So
still
Dr.
walking
Kane-
on
So much
this
for
knee
predicting.
all over the place. And he gives me the injections. What is it I get? Cortisone?
Yes, it's a type of cortisone called dexamethasone.
He calls it a cocktail.
Cocktail. We mix a cocktail up for him, and he comes in, and he's good. It lasts him a long time. Everybody's different,
So
Yes.
will the supplementation then only last 10 months, or?
The studies that we've seen nationally and that I've experienced personally is somewhere between 6 and 12 months. And everybody's a little bit different. Some people go like 18 months, though. But if you have to come in and get a shot a week that lasts you 6 to 12 months, sign me up for that every day rather than an operation. I just should not operate on you.
But then I'd be able to do it after the 10 months or again, or?
Yes, yeah. I've got some patients I've got on their 7th and 8th, 9th series of these things. So they would have had a knee replacement 7 or 8, 9 years ago, and now they haven't got a knee replacement. They still got their own God-given equipment in there, and they can pop in for the shot, and they call me the week that it wears off. They just go, wore off last week, sign me up. Excellent. My job is not to become a millionaire. My job is not to do the most surgeries of anybody else or anything like that. My job is to try to make patients' lives better and do it the best way possible, and hopefully without operating on them.
So it's
Okay,
kind
yeah.
of like a replacement for the cartilage then?
The knee replacement is a replacement for the cartilage. That's basically what it is. The actual replacement for the joint fluid, or the substitution for it, is the gel viscosupplementation. So what we're doing is trying to get that knee to function better and hurt less.
Okay, next question. Anybody else have a question back here? Oh, right here? Two here? Oh, sorry.
So my sister is from Sweden, and she's got arthritis in her hands, her knees, her hip. So she's got a lot of pain, but it just kind of went away. So what should she do to help it? Excuse me, the pain has not gone away. What could she do to help the pain go away?
So your sister in Sweden has got pain from arthritis, but nothing is making it go away. Is that correct?
Correct.
Okay. And, well, if it's in her hips or her knees, and she's in Sweden now, aren't we all told by the people on TV that Sweden has the best healthcare system? How'd this happen? Okay, so, yeah, right, yeah. Okay, there's the truth from somebody that knows. Okay, so the answer is, if it's her hips or her knees or even shoulder, it's very possible that that can be treated with, the treatments, non-surgical treatments that I talked about. Or does she come to the United States ever? She ever get over here?
No.
She doesn't. Okay.
She's only been to Hawaii 2 times.
Okay.
She had no pain there, but I think in Sweden, because it's colder.
Cold and damp.
Right.
she's got
Sure.
no pain there.
Okay. All
That's
right.
why I'm here.
That's why you're here? I
I'm
wonder
from
why
New
you're
York.
here. He's a
I
New
know
York
what
boy.
zero weather is like.
That's right.
I know when it's freezing cold and snow and blizzards and shoveling snow. Look at the fingers. I'm loaded with arthritis.
They have
Riddled
some
with it.
outstanding surgeons in Europe, and especially in Germany. And Sweden has quite a few too. The Swedish Joint Registry is one of the most famous in the world. So she needs to go to one of the major centers in, say, Stockholm, and to be seen, to get referred. If you want, if she has access, we all do on the internet today or with cell phones, she can take her cell phone, take a picture of her x-rays, and then give them to you. You come to my office, I'll look at them, and I'll tell you, what can be done for long distance that way. It's kind of nice to live in the world these days where you don't have to be somewhere in person.
Great. Next question. Oh, sorry, we want to get to as many questions.
Okay. Yes.
Right here? Go ahead. Oh, sorry.
Okay.
Somebody in the back? Go ahead. Sorry.
Well, way in the back. Can you
Sorry.
hear me?
Hi. Yeah,
Okay,
sure.
this is relating to my personal hip replacement 5 years ago, not relating to you all, I just from another surgeon. Several questions. Number one, is it common after the hip replacement you will have different length of the legs? That affected a lot of my posture and everything. So now I'm considering, should I redo the hip replacement or really try to look for Cinderella shoes and have to go to the place to wear totally different height of shoes? Or should I see you to get eventually to solve this problem? Because I'm going to be 75. I'm grateful that I was able to be very active. I'm still very active mentally in many ways. But physically, I know the different height is affecting, and now my knees start to have a little symptom. I go, oh my goodness. I'm so grateful tonight that I gained so much insight.
Oh, thank you. Well, yes, the answer to your question is, and for everybody else here, the number one problem that you have to, as a hip surgeon, you have to deal with is you have to make sure that patients come out as equal as possible in their leg lengths. And you can adjust that with your surgical technique by how you have to, at what level you cut the bone, how deep you place the implant, all that is super important. And if patients out of pain but their legs aren't the right length, they're very dissatisfied with the result. And so, and you say, well, I'll just get a lift for your shoe. Well, nobody wants to walk around with one shoe like this and one shoe like this. It's about quality of life. We talk about that. We got rid of the pain part. The quality of life ain't so good. So the answer to your question is it is possible to fix that. Okay, and what you need to do, that young lady sitting right next to you, to your left, is my nurse. That's Wendy, and she's been my nurse. I've been lucky enough to have her for the entire 28-year career. Yeah. She was the #1 orthopedic nurse at Queens up on the orthopedic ward, and I begged her when I started practice to come work for me, and she played hard to get for about 6 months, and just said, no, I'm sorry, I like it here in the hospital. I went, oh, God. And so I had a couple other nurses that were, I kind of tried out and stuff, and then she came to me, as God would have it, and said, that job offer still open? I said, absolutely. And so I couldn't have gotten luckier if I tried. She's super smart. She's great at dealing with people. She knows stuff. Patients are upset, correct me if I'm wrong, Bobby, if I'm not there, if I happen to be away at a meeting or on a trip, you know, they're not so concerned. If Wendy's not there, they go, where's Wendy? You know, and I go, it's okay. She and her husband went to Japan, you know, yeah, but when's she coming back? I go, it's okay. I'm here. But where's Wendy? You know, I've lost control of the practice. But the important thing is, and she can give you information on how to come in and see us. I can take a look at your case, be happy to, and give you the best advice I can as to what can be done.
She's a big part of that team.
Yeah, right? For sure.
All right.
You're welcome.
Thank you, folks. I know I want to be respectful of people's time, so I'm going to cut off the Q&As here. But again, they'll stick around if you want to ask them individual questions. But again, please, a round of applause for Dr. Kane.
Thanks.
And Bobby, please. Thank you very much. I also want to thank Val and Michelle for providing sign language interpretation. Also thanks to the Queens Medical Center's outpatient rehab. They were out there as well as the Arthritis Foundation of Hawaii, providing some great information. Thank you to our volunteers, Lisa and Sophia. Next month, our topic is reducing the risk of stroke for an irregular heartbeat. Do you or anyone you know have an irregular heartbeat? Are you taking blood thinners to reduce your risk of stroke? Did you know there are alternatives to reducing your risk of stroke aside from taking blood thinners? Dr. David Singh, an electrophysiologist, and Dr. Giselle Baquero, an interventional cardiologist, will talk about options for patients. That's next month, Wednesday, March 25th, from 5:30 to 7. Again, thank you very much for attending the Queens Medical Center Speaking of Health lecture. Feel free to come up and ask any follow-up questions you have. Thank you, and drive home safely.